This is the third module, module number 3 on acute dyspnea series or dyspnea series, and this is mainly focused on how to take a focused clinical history in a sequential manner, how to perform a pattern-based clinical examination, and what to look for in the pattern recognition and clinical examination for patients with dyspnea. So in terms of the history taking, the context really matters. In our second module about the first 15 minutes in ED, we talked about the life-threatening complications. So again, if you're working in ED, the history must be brief, focused on the specific particular questions, collateral history from family, relatives, or the first responders. And the priority would be life-saving measures because it's a critical situation. Then again, a detailed history can follow. You have to stabilize the patient, A, B, C, D, E approach that we discussed before. Now, if it's an inpatient setting or outpatient setting, then obviously you've got more luxury of the time at your hand. You can take more collateral history, more detailed history from the patient about occupation, drugs, social history, etc., etc. In terms of the onset and timing of shortness of breath, the rapidity of onset would indicate an acute vascular process like a pulmonary embolism, or sudden change to anatomical structure of the lung or surrounding pleura like a pneumothorax, including tension pneumothorax, extravasation of fluid into the alveolar space like flash pulmonary edema, and anaphylaxis. Coming to the positional association, anyone with shortness of breath associated with orthopnea or paroxysmal nocturnal dyspnea, when they have to wake up suddenly gasping for breath in the middle of the night. Obviously, when somebody is lying flat, 30% of the lung volume is already in the dead space. So any decompensation on top of that due to gravitation of the fluid into the lung space will lead to further decompensation of the already reduced functional reserve of the respiratory work. Hence, it would predominantly include either left ventricular failure or anatomical problem to the diaphragm itself, like diaphragmatic palsy or obesity hyperventilation syndrome. So classically, their symptoms are worse due to positional effect and especially in lying recumbent. Then coming on to the exertional component. So this means a patient's normal physiological reserve for the respiratory work or air alveolar arterial oxygenation and ventilation processes mash during sub-physiological performance, or when the body is not in high demand. But however, when they have exertion, that puts more strain on the lungs and the oxygen carrying capacity. So that means there is something to do with either conditions like ischemic heart disease, coronary artery disease, or interstitial lung disease, or any of the lung problems of parenchymal disease itself. Also, it can also indicate conditions like COPD and asthma, where there is airway bronchospasm that leads to exertional dyspnea on top of the baseline problems. Similarly, the rapidity of onset of shortness of breath gives quite a lot of clues actually. Sudden rapid onset, like if it's like sudden, like within flash of seconds, that would sometimes indicate conditions like sudden acute pulmonary embolism, pleuritic chest pain, sudden decompensation, shortness of breath from nowhere. Same as pneumothorax, including tension pneumothorax. So mild pneumothorax can evolve over a period of time. Sometimes it can take a few days to a few minutes to a few hours to sometimes maybe a few days if it's very subtle or minute. But a tension pneumothorax will present very, very rapidly. Similarly, acute severe asthma, the onset can be very severe. Anaphylaxis, classic example of airway obstruction and sudden swelling of the tongue and upper airways and inflammation of the upper airways can be life-threatening. And flash pulmonary edema, acute pulmonary edema due to acute MI, ruptured ventricular septal defect, or mitral valve regurgitation, any of those conditions can lead to sudden rapid onset, which can be within minutes to maximum hours. In contrast to that, if it's a slower onset, like you're talking about hours to days, we can have conditions like infections, for example, pneumonia, COPD exacerbation, interstitial lung disease, which has got a chronic continuum. So baseline shortness of breath interspersed with exacerbation, which can lead to progressive gradual onset, more of a subacute onset. In contrast to this, any history which dates to like a few weeks, you're talking about slow indolent processes like tuberculosis, valvular heart disease, interstitial lung disease. As we said before, it's a slow progression over weeks and weeks. Pleural processes like pleural thickening and mesothelioma, the history can be weeks to years. The patients can present quite late, and hence the presentation will not be acute. Same as pulmonary hypertension due to right ventricular strain, due to any strain to right ventricle due to any of the lung pathology, lung problem leading to pulmonary hypertension. So obesity, chronic pulmonary embolism, all these conditions leading to pulmonary hypertension will lead to insidious onset of shortness of breath. Similarly, shortness of breath due to postural changes, for example, orthopnea, which is literally orthopnea, a combination of two words, which means breathing upright, which means the breathing is better upright and worse on recumbency. So any conditions which lead to increased venous return, for example, heart failure, COPD, all those conditions when the patient is lying supine, there is increased venous return to the heart, increased pulmonary vascular pressure, and also due to the diaphragmatic splinting and mucus plugging, multiple reasons, and there is an increased left ventricular end diastolic pressure leading to a lot of fluid extravasation into the lung parenchyma itself. All these eventually over a period of time, overnight, lead to orthopnea, which means the breathing is worse on lying flat and better on getting up due to the effect of the gravity and the and all the reduced venous return to the heart, better oxygenation, better diaphragmatic movement, etc., etc. So pulmonary obesity, pulmonary edema, obesity, heart failure, as we discussed all of them. The converse of this is platypnea, which literally means platy is from lying flat, and pnea is breathing. So any breathing which is better on lying flat and worse on sitting upright and mobilizing. This is like postural, sorry, not mobility, due to sitting or standing improves the breathing. Now, this is an interesting condition. Anything which like a sudden pulmonary embolism, which leads to shunting of the blood, like there is alveolar arterial mismatch, so VQ mismatch, and also conditions with when there is intracardiac shunting, AV malformations, pulmonary AV malformation, intracardiac shunt due to ASDs and VSDs, and all of those conditions. When somebody is lying, is standing up, the shunt increases, and hence the deoxygenation is more. That's why they're called platypnea, orthodeoxia syndrome. It's an interesting theoretical question which may come up in MRCP parts 1 or any the clinical exams for like USMLE, etc. Also, with shortness of breath, one of the very common symptoms is cough. So characterizing the cough itself from the patient is very important, asking whether the cough is productive, dry, or if it's productive, whether it's associated with any blood in it. So in terms of the productive cough, again, it depends on the qualification and quantification of the sputum production. Is it mucoid, white? Is it green, yellow, etc.? And looking at the productivity of the cough, some of the infective etiologies like COPD, asthma exacerbations, bronchiectasis usually has a chronic productive cough, but due to the pyrrhus is increased during acute exacerbations. Similarly, if there is a productive cough, but just like pink blood tinged sputum, not frank hemoptysis, usually indicative of pulmonary edema. And any chronic productive cough, especially with weight loss, night sweats, all the B symptoms, loss of appetite, and a positive, strong social history indicative of pulmonary tuberculosis should raise suspicions. In terms of dry cough, anything which leads to an irritant cough, for example, interstitial lung disease or viral pneumonias, viral upper respiratory tract infection, lower respiratory tract infections. Also, central airway tumors can also lead to irritant, non-productive dry cough, and neuromuscular disease can lead to very weak and absent type of a dry cough. In terms of hemoptysis, conditions which can lead to hemoptysis, if it's acute history, then usually pulmonary embolism due to pulmonary infarction, and hence the blood coming with the productive sputum. Lung tumors, airway, central tumors, and bronchogenic carcinomas, they can also lead to hemoptysis. Fistula formation between if it's a pulmonary AVM, that can also lead to hemoptysis. Bronchopulmonary aspergillosis and the cavitating lung lesions, if there is an acute decompensation, if there is a secondary infection there, and sometimes one of the vessels can rupture due to coughing or infection, that can lead to hemoptysis. Vasculitides, if it affects the pulmonary vessels and the that can lead to hemoptysis. Or acute bronchitis, if it's severe enough, then it's more of a blood streaking due to the inflammation of the mucosa rather than frank hemoptysis, but that can also be one cause of hemoptysis. Coming to breathlessness with wheezing, I know wheezing is more part of a clinical examination part, but sometimes the patients will report noisy breathing and whistling sound from the chest. So they are very particular about qualifying the symptoms. So if it's a polyphonic wheeze, think of conditions like generalized airway obstruction like asthma, COPDs, and sometimes a viral bronchiolitis. It can also lead to generalized wheezing. If it's a monophonic wheeze, that is usually indicative of a localized problem rather than a systemic generalized lung problem itself. So any localized tumor or a foreign body in upper airways or a mucus plugging affecting one particular anatomical location, that's usually linked to monophonic wheeze in that particular area. In terms of investigations, we'll come to investigations part of the next module, but just to emphasize that monophonic wheeze, as due to the localization of the etiopathology or the causative agent, will usually have an abnormal chest X-ray and requires definitely specialist referral. Now, other associated symptoms with shortness of breath can be quite crucial. For example, if it's a chest pain, think of cardiac or respiratory causes like in cardiac it will include myocardial infarction, ischemic heart disease. Similarly, any major pulmonary embolism can also lead to chest pain and shortness of breath. Small PE, especially subacute or chronic, can lead to shortness of breath and chest pain, pneumonias, and also if it's sudden onset, pneumothorax. In terms of cough and fever, we just touched on it before. Any infective etiologies, pneumonia, viral and bacterial lower respiratory tract infections. If it's a chronic history of cough and fever with weight loss, it could be tuberculosis or any undulated infections. Noisy breathing, as we just discussed in the previous slide, suggests more of an obstruction. Smoking history is really crucial in shortness of breath, and quantifying and qualifying is important. So we only attribute smoking as cigarette smoking, but always think about cannabis and the rolled tobacco. Now, in terms of the smoking history, the risk is cumulative. So over a lifetime, the total amount of cigarettes or cigarettes smoked is linked directly, linearly, to risk of development of COPD and lung cancer. So any smoking history of more than 20 pack years significantly increases that risk. Similarly, cannabis is 5 times more harmful to lungs than tobacco, and one joint is equal to roughly like 5 cigarettes. In terms of pack year calculations, you ask them how many average number of cigarettes they smoke per day, and we know that 20 cigarettes constitute 1 pack. So whatever the number of cigarettes per day divided by 20 will give you the number of packs per day multiplied by how many years smoked. So as an example, if somebody is smoking 20 cigarettes a day, that is 20 by 20, which is 1 pack. And if the smoking history is like 30 years, that's 30 pack years. Similarly, if somebody is smoking 30 cigarettes a day, that will make it 30 divided by 20, 1.5 packs per day. And hence, if it's a 30-year history, you're talking about 45 pack years. So this is how you calculate. Coming to the importance of past medical history, it's needless to say it's really crucial to ask about previous clinical conditions, including cardiac, respiratory, diabetes, neuromuscular disease, any pre-existing ischemic heart disease, conditions like diabetes, or you can think about the DKA or HHS complicating the acid-base balance, neuromuscular conditions, myotonic dystrophy, motor neuron disease. Similarly, history of malignancies, and again lung metastases can lead to pulmonary carcinomatosis, and also risk of higher pulmonary embolism and pleural and pericardial effusion. Also chemotherapy side effects, so sometimes it can be directly toxic to the lungs, and also radiation therapy for previous lung malignancies can also, or adjoining areas can lead to radiation fibrosis to the lung itself and lead to chronic shortness of breath or subacute onset. In terms of systemic conditions, any inflammatory conditions like vasculitis or SLE, rheumatoid arthritis, it can be the disease itself or the manifestation of the treatment like methotrexate, and that can also lead to shortness of breath. HIV, especially if anybody with new interstitial lung disease or new onset of pulmonary tuberculosis without any obvious risk factors, think of systemic immunosuppression like HIV. Occupation and environmental history is really important. A lot of occupation, especially if there is a latency between the occupation and the presentation. So think of mining, asbestosis related to the construction and plumbing work, especially people who worked in the 1970s and 80s. They may have a latency of 20 to 30 years before presenting. Similarly, asthma can have a lot of chemical agents used in spray paints and glutaraldehyde, and these can trigger the asthma presentations. Hypersensitivity in people working in different farms and bakery shops, and also bird fancier's disease due to pigeons can also lead to hypersensitivity, pneumonitis, and shortness of breath. So detailed occupational history is really important. May not necessarily be evident in acute emergency situations, but it's critical to address people with subacute to chronic recurrent shortness of breath history. Like in so many other important aspects, medication and drug history is really crucial, especially in patients with dyspnea. The mechanisms can be the direct toxicity and causing interstitial lung disease, or acute pneumonitis, or other respiratory symptoms because of airway inflammation or allergies. So a lot of common groups of medications surprisingly can cause respiratory symptoms, and especially dyspnea. From cardiovascular point of view, ACE inhibitors due to the dry cough, beta blockers which can aggravate asthma, and even calcium channel blockers can lead to respiratory symptoms and breathlessness. Non-steroidals can lead to bronchoconstriction in susceptible patients, and also lead to fluid retention, which can worsen heart failure and shortness of breath. Some of the antibiotics can cause pneumonitis and inflammation of the lungs, for example nitrofurantoin, and it can also lead to eosinophilia. Chemotherapeutic agents, we discussed about SLE and rheumatoid arthritis. If methotrexate is used, then it can lead to idiosyncratic reaction in pulmonary fibrosis and interstitial lung disease in the long run. Similarly, family history and shortness of breath is really crucial. A lot of genetic risk factors for atopy, asthma can be familial. Also, history of venous thromboembolism in patients who do not seem to have any obvious risk factors. Think of the factor V Leiden deficiency, protein C and S deficiency, which can have familial tendencies as well. Young patients coming in with history or symptoms or radiological findings of emphysema without any smoking history should alert to alpha-1 antitrypsin deficiency, which can run in families. Also, cardiac history in families, premature deaths at young age in the families, and also sudden unexplained deaths in young people, history of cardiomyopathies, hypertrophic obstructive cardiomyopathy, etc. Similarly, any history of tuberculosis in the family or sick contacts can alert to the possibility of chronicity of symptoms, productive cough, weight loss, night sweats, etc. Also, travel history in acute settings, for example, venous thromboembolism, long haul flights, immobilization for a long time, is a risk. Any travel history recently will be a risk factor. Certain travel to certain parts of the world will have geographic tendencies of some of the conditions, like tuberculosis. It can be endemic in high incidence areas, so that is really crucial. Fungal parasitic infections leading to histoplasmosis and respiratory symptoms can be due to that. The MERS and SARS viruses we recently had in the last few years, although those respiratory etiologies, however, now because of the global traveling, and it has become less of a concern. However, still relevant endemic area history is really crucial. Scuba diving, any history of recent diving and decompression sickness can alert to this possibility as well. Just recapping the social history, we have touched upon it in the previous few slides. A history of smoking, please refer to the earlier slide that we discussed about the tobacco, cannabis, and even vaping itself can lead to lipoid pneumonias and chronic shortness of breath and parenchymal lung changes. Alcohol and other drugs can also lead to problems and shortness of breath. Aspiration pneumonitis due to alcoholic cardiomyopathy can lead to heart failures, and so it has relevance. We don't think and attribute alcohol to respiratory problems, but it can. Cocaine can lead to pulmonary hemorrhage and vasoconstriction, so acute history of cocaine ingestion can also cause problems. Pets and environment we discussed before, so occupational history of pets is really crucial in assessing dyspnea. So quickly putting together the red flags: any shortness of breath with hemoptysis, think of pulmonary embolism, malignancy, or pulmonary hemorrhage. Shortness of breath with leg swelling, think of DVT and pulmonary embolism, especially if it's unilateral leg swelling. If it's bilateral, think of heart failures. If you've got reduced breath sound on one side and shortness of breath, think of pneumothorax. If there is history of fever, especially acute history, fever, productive cough, pleuritic chest pain, think of pneumonia. And finally, the summary for the history taking part of dyspnea. Do not forget some of the key factors in terms of the onset of dyspnea between rapid and insidious, and all the features. Don't miss silent angina or platypnea, because these can be some of the rare causes of shortness of breath. Always think of cough and characterize it from in terms of purulence and dry or sputum or hemoptysis and differentials accordingly. Quantifying smoking, just saying that there is a positive smoking history is not enough. You have to quantify, because it has a relevance and importance in terms of the risk factors for COPD and malignancy down the line. Always check the occupational history, drug history, pets, and to explain the dyspnea. Okay everyone, so now coming to the clinical examination part, and I must say that the next two slides are from my module 2, which is the ED approach. So I'm just going to use those two slides, and you will find me in a different attire, in a different suit, so don't be alarmed. I'll come back in the following slide. The initial safety approach, A, B, C, D, E, primary survey. A for airway, looking for the patency, whether the patient can speak and respond to voice. That means the airway is patent, or if there's any stridor suggesting upper airway obstruction. B for breathing, looking for the respiratory rate, oxygen saturations, work of breathing, and also chest auscultation for breath sounds. C for circulation, looking for the blood pressure, heart rate, capillary refill, peripheral and central, and auscultating the heart sounds. D disability, which is for the neurological status. FView scoring, alert, responding to voice, pain, unresponsive in some countries, whether it's applicable, or 15-point GCS, whichever your local protocol suggests, just go for that. CO2 testing, and also checking for the blood sugars. E for rashes, also signs of DVT, because it could be relevant as a source for pulmonary embolism, and other systemic exam as relevant. So E is everything else or exposure. The immediate actions that you need to do are OMIV. So these actions are sequential. So going at the same time as you're doing the ABCD approach, you don't have to finish the approach before you proceed to these. So OMIV stands for oxygen, monitor, IV access, and vitals. Oxygen, titrate according to requirement, but as high as possible if it's appropriate. Usually a target is 94 to 98, except COPD when it could be 88 to 92, you can lower it down. Monitoring, immediately attaching the cardiac monitor for rhythm, and also peripheral pulse oximetry for saturations, and blood pressure monitoring as appropriate. IV access, ideally 2 large bore IV access for immediate immediately securing vascular access in case there's a peri-arrest situation. So you should not be losing the critical vascular access, either a green or a gray Van Fleon. Size 18, 16, 18 gauge, the higher the better. In terms of, and last is a V, vital, so baseline neurological status, temperature, respiratory rate, and also blood pressure, but keep monitoring frequently. That is a key thing in this situation. Let's look at the importance of some of these vital signs from dyspnea point of view. Respiratory rate, obviously, if it's tachypnea, that indicates increased rate of breathing, and it could indicate increased work of breathing as well. So anything above 24 breaths per minute, you should start thinking about alarm bells, because one of the first signs, in fact probably the first sign which becomes abnormal in any sick patient, and especially with the metabolic acidosis or any acidosis, the chemoreceptors, they sense the change in acid-base balance. Please refer to module 1, the fundamentals and etiology of dyspnea. So the first compensation is by the effector, the brain, to the respiratory muscles, which is to increase the respiratory rate, hence to try and blow off the CO2 and acidic gas and normalize, and in an attempt to normalize the acid-base balance towards sort of normal status, so that pH is neutralized and hence the acidosis is reversed. So tachypnea is one of the first signs which should alert, even before hemodynamic instability or hypoxia or anything else. In fact, tachypnea will be one of the first triggers even in hypoxemia, because it will try and increase the oxygenation. So the patient may still not be hypoxic at that point. So tachypnea, please remember. The other thing in respiratory examination, respiratory rate, is the use of accessory muscles, sternocleidomastoids, scalenes, stabilization of the the rib cage, intercostals. These are the primary, but scalenes and the sternocleidomastoid and using the supporting structure of the rib cage itself, other than the primary muscles which are intercostals, the diaphragm. If you come across the accessory muscles, this means the patient is struggling because these muscles are not usually at work during the normal breathing patterns. Then looking at the oxygen saturations, but you should also assess, is a patient breathing ambient room air or is a patient on supplemental oxygen. So that's the respiratory rate part. Coming to the pulse rate, again, tachycardia would also indicate a SIRS response, systemic inflammatory response syndrome, or it could be indicative of sepsis, or purely a physiological response of the body to hypoxemia, acid-base balance, or even hemodynamic instability. So tachycardia, again, it's a poor sign, it's a bad sign. Same as bradycardia. If somebody has got life-threatening severity of acute respiratory arrest, then it could also be indicative of either a primary cardiac problem or a secondary problem affecting the heart itself. So bradycardia should also alert. Blood pressure. Now, initially blood pressure may be normal. However, hypotension is a bad prognostic sign. It clearly means there is now hemodynamic instability and it might lead to impending respiratory arrest. So these are some of the parameters in vitals which you should assess. And please refer to our module 2 of ED approach for more details. So one of the first things is the general inspection of the patient, and that's what I call it as the end of bedogram. So assessing the end of bed test, or how does the patient look. First of all, the position of the patient, because in dyspnea you might come across that the patient is either lying flat, which would indicate that there isn't much of a respiratory distress or compromise. However, if they are tripoding, like trying to hunch forward and stabilize the chest wall by using both hands and the body, that's a worrying sign, and that would indicate the second part, which is the effort of breathing, which means the accessory muscles of respiration are in use. In normal breathing, we touched a little while earlier. So the primary muscles of respiration are intercostals and diaphragm, which are working during rest. Obviously, it's an automatic activity, autonomous activity. You don't even think about it unless you are consciously taking a deep breath in. However, if and when the physiological reserve is met at its maximum, and despite intercostals and diaphragm, the respiratory effort is not enough for the oxygen delivery of the body and removal of carbon dioxide, so the oxygenation and ventilatory mechanism is not fully compensated, then at that point, and this is at the height, at the peak of their working, then the accessory muscles come into play. And the accessory muscles will include the neck muscles, the rest of the shoulder and chest wall, and the abdominal muscles. In the neck, you have the sternocleidomastoids and the scalenes. In the upper chest and back, you have pectoralis major, minor, serratus anterior, trapezius and latissimus dorsi. And the abdominal muscles will include the rectus abdominis muscles, the recti, the obliques, and the transverse abdominis. Now, what they do is they are assisting the primary muscles in further movement of the chest and the diaphragmatic movement, so that during ventilation, the exhalation part is accentuated by the diaphragmatic movement, and while the other muscles, they are helping in the inspiratory mechanism, in the inspiratory phase of the breathing. So that's where the effort of breathing should be inspected. Thirdly, the speech. Is the patient able to complete full sentences? Yes, no. And we have touched on it in our ED module number 2. That's a worrying sign if they are unable to complete respiratory, like full sentences, which would indicate respiratory distress. What's their complexion and color like? Are they cyanosed, or do they look pale? Anemia could be the reason for breathlessness. Cyanosis, we've touched on it. It could indicate poor oxygen delivery. Are they confused or drowsy? This is also not a good sign. It could indicate signs of either CO2 retention causing hypercarbia and confusional state or drowsiness, or it could be purely because of poor oxygenation of the brain itself. So if you look at our module 2, this is one of the first slides in the module 2, which is the differentiation between a sick and a very sick patient. So this is the inspection part of the patient as a whole before you move on to the inspection of the chest and respiratory system in itself. Okay, so after the chest inspection and the JVP, let's come on to some of the systemic signs. Now, I must say here that this video about the examination part is not about the technique and the steps of examination as such. We'll come to in some of those videos. We will do the full respiratory exam, the sequence, and all that. This is more of a pattern recognition and some of the signs. So, if you look at the clubbing, it should be part of the inspection, part of the general examination of the respiratory system, which is to start with hands, nails, signs of CO2 retention, like a flap, CO2 flap due to high CO2 in the blood, hypercarbia, pulse for rate rhythm, etc., etc. Then you go up and neck and face and anemia, pallor, cyanosis, etc., etc. But however, I'm just trying to focus on the pattern. So this in the systemic signs related to respiratory, you're talking about the hands and especially nails, ankles, and abdominal paradox. It's more of a pattern that I want to focus on. So clubbing, one of some of the commonest causes, you know about the beautiful mnemonic, which is very common for clubbing, is CLUBBING. So if you look at the causes of clubbing, you're talking about cyanotic or congenital heart disease and cystic fibrosis. L stands for lung cancer and lung abscess. U is ulcerative colitis. B is bronchogenic carcinoma and also bronchiectasis. The B also stands for benign mesothelioma. I is infective endocarditis and idiopathic pulmonary fibrosis and neurogenic tumors, and G is for gastrointestinal diseases like Crohn's disease or enteritis. Now, in terms of the respiratory signs as such, you're talking about, or the respiratory causes, should I say, idiopathic pulmonary fibrosis, lung cancer, benign mesothelioma, as we discussed before, chronic infective conditions like bronchiectasis and empyema. The ankle swelling, will come to that later also, but biventricular cardiac failure and also right heart failure, which is indicative of pulmonary and pulmonary hypertension. Abdominal paradox, one of the very overlooked signs, is if somebody is in supine position and the abdomen is sucked inwards during inspiration, which should not be the case, because if you're inspiring, the abdomen should be protruding out. But if there is a diaphragmatic palsy, then and the paralysis and muscle weakness, then the diaphragm will be sucked in. So that's an abdominal paradox, which means it should not occur in a normal situation. In terms of general inspection for the respiratory system, whether it's front of the chest or behind, so one of the key things in inspection, you need to look at the size, shape, symmetry, and the movement of the chest wall itself. The shape of the chest, if it's barrel shaped, that would indicate conditions like hyperinflation, for example, emphysema. Previous surgical scars would indicate some sort of intervention or resection or pneumonectomy, partial pneumonectomy, or lobectomy for that matter. If there is deformity of the chest wall itself, that could indicate kyphoscoliosis, and asymmetry of the chest wall movement, like one part is moving less and the other is moving more, could indicate either a local problem like a lobar collapse or even like a pneumothorax. And so that will be important in inspection. The other inspection part is the JVP. Obviously, the jugular venous pressure, if it's elevated, that would indicate either a biventricular cardiac failure or right heart failure on its own due to pulmonary embolism or cor pulmonale, pulmonary hypertension, and also it might indicate pericardial disease like cardiac tamponade, which we have discussed in our module 2. So after inspection, we now go on to the palpation and percussion of the chest itself. In the palpation part, from respiratory system point of view, the mnemonic is at the front of the chest is FATE, fremitus, apex B, trachea, and expansion. So if you look at the trachea, the signs indicating gross pathology will be that if the trachea, when felt from the thyroid cartilage, if you go down right up to the sternal notch and just feel whether it's in the center or deviated to one side or the other. So this is how the general inspection is. We'll come to that in the examination module sometime later. Anyhow, if the trachea is deviated, the question is it pulled to the one side or pushed to the opposite side? So if it's towards the lesion, if it's pulled, this means there is loss of volume on that ipsilateral side where it is pulled towards. So either a collapse or a fibrosis or history of surgery like a pneumonectomy of that part of the lung. If it's pushed to the opposite side, so instead of pulling on the right side, if it's pushed to the right side from the left, think of something which is pushing it from the opposite side. So what exactly could that be? That could indicate a tension pneumothorax. So if there is a massive amount of pressure in the pleural space due to the air, excessive air, and the lung is literally collapsed and it's pushing it to the opposite side. Same as if the normal lubricating fluid, which is just like tiny amount to bare enough to lubricate the parietal and visceral pleura, if that is replaced with a massive amount of pleural effusion, that can also push the trachea to the opposite side. Same as from the dullness point of view. If it's pleural effusion, it will be stony dull to percussion, or if there is thickening of the pleura, or if there is underlying consolidation of the part of the lung. And raised hemidiaphragm can also lead to false dull, false sign of a dullness, which is not due to the lung pathology or the pleural pathology itself, but it's due to the raised hemidiaphragm. In fact, this is one of the key questions or key differentials to consider when you've got MRCP PACES exam or any clinical examination. Then signs of a raised hemidiaphragm. So basal dullness, one of the differentials would be signs of a raised hemidiaphragm. Hyperresonance would indicate, on the contrary, would indicate increased presence of air in the pleural space, like a pneumothorax. However, it may not be that easy to elicit, especially if there is a busy environment or a noisy workplace. So you have to, and that's why the comparison between the two sides will be really crucial. Auscultation of the breath sounds. If there is evidence of bronchial breathing on any particular part of the chest wall, that would signify or suggest possibility of consolidation like pneumonia. Look for associated signs like tactile vocal resonance or vocal fremitus, because that should also be increased with the consolidation. And whispering pectoriloquy is a sign when a patient whispers something like saying 1, 2, 3. In a normal situation, you should not be able to auscultate over the chest wall with a stethoscope. The sound should be very muffled or barely, should not be audible in the normal situation, because air doesn't conduct the sounds properly. But if there is a tenacious material like consolidation, the conduction of that whispered sound will be far greater and better, and you should be able to hear it. Auscultation, second part, other than the type of breath sounds, you need to look for the added sounds. For example, crackles, one of the most common signs to come up. Look at the pattern. Are they bilateral or unilateral or other pattern? If they are bilateral and they persist after coughing, think of pulmonary edema, heart failure, because usually it's a bilateral finding, and usually the crackles will be coarse. If the crackles are bilateral, more predominantly at the bases, and are fine crackles like a Velcro opening, or the sound produced by rubbing your hair close to the ears. If you just do that and just hear, this is the fine sound of fine crackles due to pulmonary fibrosis or ILD. Also alveolitis, any form of alveolitis, whether it's immune, infectious alveolitis, that can also lead to bilateral crackles. On the other hand, if the crackles are unilateral, and especially if they are focal, then think of pneumonia as one of the causes, like consolidation, because usually speaking, it's unilateral, especially bacterial pneumonias. And the other pattern is if the crackles clear after coughing, like what we call post-tussive, ask the patient. You hear the crackles, ask the patient to cough, and a few times, especially with good power, good strength. If they clear, then it means either the alveoli were collapsed and hence they're opening up, for example, atelectasis, or conditions like COPD and bronchiectasis, when it's a chronic condition, chronic sputum production, but when they cough, that particular part clears that mucus up, and eventually the crackles disappear. So that's another a very interesting and useful clinical sign. Coming to the other added sounds, wheeze and stridor are the two of the most common ones. Wheeze is the most likely causes are diffuse airways, obstruction of the smaller airways, especially noticed in acute severe asthma exacerbations, as well as COPD exacerbations. Usually speaking, they are polyphonic wheeze, okay, and heard throughout the lung fields. Depending upon the severity, may be mild, moderate, or severe. That indicates narrowing of the airway and the resistance of the air, expiration of the air. So that's why you hear them during expiratory phases. In terms of stridor, it indicates major upper airway obstruction, and it can be a medical emergency. So whenever you come across anyone with stridor, you should always be alerted, because it could be infections like a croup or tracheobronchitis, epiglottitis, any upper airway obstruction. It could be a foreign body, severe anaphylactic reaction or allergic reactions. That again indicates edema of the upper airways. We have discussed about the anaphylaxis in our module 2 in AD. So when if it come across with stridor, it's most likely a medical emergency that has to be dealt with in acute phases. However, some chronic conditions, like especially in children or people with laryngomalacia, can also have chronic stridor. So that's a different thing. Okay, now let's just quickly focus on some of the pleural signs. Now, pleural rub. In a normal situation, the pleura are lubricated against each other, and the visceral and parietal pleura, and there should be no audible sound at all. So whenever there's pleural inflammation, pleural based inflammation, then you might be able to hear some pleural rub. So and it's more like a grating and rubbing sound on auscultation. Pneumonia is one of the causes. Pulmonary embolism, because it's a peripheral infarction of the lung tissue itself. That infarction eventually spills over and involves a visceral pleura, and hence there is inflammation, focal inflammation. Viral pleurisy, very common cause, just like viral pericarditis. So viral pleurisy can also lead to, and viral pleuritis can lead to pleural rub. Vasculitis, same mechanism, inflammation affecting the pleural surfaces and pleural lining. The other pleural signs are vocal fremitus and resonance. Now, between the two pleural spaces, between the two pleural surfaces, the potential space, if it's filled with something, let's say if there is effusion or air, then that increases the interface between the lung parenchyma and the stethoscope, which is on top of the surface. So when that is increased, the conduction of the air is reduced. The conduction of the breath sounds is reduced due to that interface. So hence both the vocal fremitus and tactile vocal resonance will be reduced, because the pleural cavity is a totally closed space, not communicating directly with the lung substance itself, the lung parenchyma itself. Now, on the contrary, if there is consolidation inside, and there is no pleural effusion or pleural or pneumothorax or for that matter, then the same conduction from that part of the air, which is now replaced with a fluid, is increased, and hence the tactile vocal fremitus and the tactile resonance and vocal fremitus will both be increased. So if there is fluid or air, the conduction will be reduced because it's a totally separate space. So this is a confusing concept for students and junior doctors, but please try and understand the pathophysiology and the logic of the air conduction behind it, and that will be easier. We will touch upon it in one of the clinical examination sessions for respiratory as well in detail. Also, the association of leg edema with dyspnea. If it's bilateral leg edema, most probable causes would be heart failure, congestive cardiac failure, especially biventricular failure. Cor pulmonale or right heart failure can also lead to lower limb edema, and also there will be signs of hepatomegaly, ascites, and liver congestion in addition to the leg edema. If there is unilateral leg edema and the calf is swollen, indurated, tender, or the leg is swollen, then with dyspnea, think about acute pulmonary embolism due to most probable venous thromboembolism from a DVT of the ipsilateral side. I think this is a very useful slide for students, residents, trainees, medical doctors. So let's summarize some of the clinical signs of the parenchymal and cardiac etiologies for dyspnea. Now, if you look at it, we've got four main conditions: asthma, COPD as one, cardiac failure, pulmonary fibrosis, and bronchiectasis. So let's go in a sequential manner and compare each changes of each sign. So in terms of chest wall expansion, in asthma and COPD, it might be hyperexpanded or reduced depending upon the clinical situation. In cardiac failure, the expansion usually should be normal because it's not the air trapping mechanism. In pulmonary fibrosis, obviously because the lungs are fibrosed, shrunken, so the expansion generally should be symmetric and reduced. In bronchiectasis, it should be relatively normal. Now, coming to the percussion note, in asthma and COPD, it would be predominantly normal unless it's complicated with the pneumothorax and all that. In cardiac failure, it will be the percussion note will be dull, especially at the bases, especially if it's associated with bilateral pleural effusion. While the percussion note in pulmonary fibrosis and bronchiectasis should be relatively normal. The only exception is if in bronchiectasis, if there is a lobar pneumonia or air specific specification secondary pneumonia due to bronchiectasis, then that's a different thing. In terms of the breath sounds, in all four conditions should be normal vesicular. The pneumonia as a differential will be on the next slide, but if there's pneumonia, then you would expect a bronchial breathing. In terms of the added sounds in asthma and COPD, obviously it's an airway obstruction, so you would expect a polyphonic wheeze. In heart failure, you would expect bibasal crackles. In pulmonary fibrosis, it will be fine crackles, more Velcro type, we discussed previously. In bronchiectasis, you would expect coarse crackles plus minus wheezing depending upon the severity of bronchiectasis. Now, summary of signs for the pleural and airway. 4 conditions: pneumothorax, pleural effusion, pneumonia, and collapse. We have the same 3 signs, same 3 clinical signs to pick: expansion, percussion, breath sounds, but in addition, we have trachea as well. Let's focus on the trachea. In pneumothorax and pleural effusion, it will be pushed away towards the normal side. So if there's a massive pneumothorax, like a tension pneumothorax, and massive pleural effusion, it will be pushed. In pneumonia, it should be central. In lung collapse, especially if it's upper lobe or upper zone collapse, it will be pulled towards the collapse side. Expansion should be generally reduced in all of them: pneumothorax, effusion, also pneumonia depending upon the extent and the size of pneumonia, and same as collapse, it should be expansion should be reduced. In terms of the percussion node, in pneumothorax it will be hyperresonant, in pleural effusion it will be stony dull, in collapse and pneumonia it will be dull to percussion. Breath sounds in pneumothorax and pleural effusion, they will be either reduced or absent depending upon the size. In pneumonia, it will be bronchial breathing and coarse crackles in the zone affected, while in lung collapse they will be either absent or reduced depending upon the degree of collapse. A clinical pearl to medical students, residents, trainees who appear in exam: please do not use the term breaths that the air entry is equal on both sides or air entry is reduced. You cannot measure air entry by auscultation. You have to use the term as a purist. If you want to be more accurate, you should be using the term the breath sound intensity seems diminished or normal or accentuated, etc., depending upon the clinical situation. For the differential diagnosis framework of dyspnea based on history and clinical examination, please refer to module 1. I can't go into more details here, but the etiology and etiopathiology of dyspnea predominantly falls into 4 categories: cardiac, pulmonary, cardiopulmonary or cardiorespiratory, and others. Now, the cardiopulmonary predominantly form about 80-85% of the cases of dyspnea, and the rest form like 15%. So, in terms of cardiac, you've got conditions like decompensated heart failure, acute coronary syndrome, MI, arrhythmias, valve emergencies. So, please refer to module 1. Pulmonary, you have airway disease, parenchymal disease, pleural disease. Again, differentials are wide. Mixed cardiorespiratory could be both COPD plus heart failure, cor pulmonale, COPD, and there is no doubt that heart and lungs go hand in hand together. Others could be anemia, diabetic ketoacidosis, sepsis, neuromuscular, anxiety, and obesity, hypoventilation. So whenever you come across any OSCE clinical question or any clinical exam setting, think of the diagnostic framework based on a systematic approach of classification. So please refer to module 1, don't forget that. Now, putting all those differential diagnosis framework into some of the mini cases. Case 1, an older hypertensive patient coming with orthopnea, pink frothy sputum, bilateral crackles, and it has got a third heart sound. Most likely diagnosis, acute pulmonary edema. Case number 2, young asthmatic, severe wheezing, reduced peak expiratory flow rate, silent chest, and exhaustion. So there is no doubt there is asthma, but the signs of silent chest and exhaustion lead to thinking of life-threatening or acute severe asthma. Please refer to module 2 ED assessment. Case number 3, post-operative sudden pleuritic pain, tachypnea, tachycardia, normal chest x-ray, day 2 post-operative, day 3 post-operative, high probability of pulmonary embolism unless and until proven otherwise. Case number 4, a tall, thin, young male, sudden pleuritic pain, unilateral absent breath sounds, think of spontaneous pneumothorax. Again, depending upon the severity, is it tension or not, it depends upon the clinical scenario. Quick summary of the examination section of this module. Vital signs, please, they're really crucial. So tachypnea, desaturation, hypotension, poor prognostic signs, and indicate clinical urgency. Also remember, differentiate stridor from wheeze. Stridor can be a life-threatening emergency, so airway protection is crucial. Now, inspection of the scars and shape is really important in clinical examination. This is one of the most overlooked examination techniques. And if there is pleural effusion or signs of pleural effusion, before tapping, do the necessary imaging to confirm, because it could be a diaphragmatic collapse. So exam corner lastly, and some of the exam tips. All when you have a long case related to respiratory or respiratory symptom as such, focus on respiratory and cardiovascular exam both, and because cardiorespiratory form at least 80 to 85% of the cases of dyspnea. And always comment on the vital signs available, so do not skip the mentioning, and especially notice any abnormality in the vital signs before explaining about the detailed chest findings. There is always a tendency to just directly go and explain about the respiratory signs, and also do not forget about the general examination of the hands and face and neck. You should always have a systematic approach: inspection followed by palpation, percussion, auscultation. In terms of synthesis, so link the signs to clinical patterns and likely diagnosis, as I said. So do not look at the sign in isolation. So if you have signs of tracheal shift, look at the lungs, the chest wall expansion, compare the percussion note, the breath sound intensity, vocal fremitus, etc., etc. And do not forget to examine the legs for signs of DVT, and also the leg edema and the sacral edema as well. So yeah, so these are some of the important and interesting clinical tips that you should never forget.